Thank you for joining this quick talk today on the use of lung ultrasound in the NICU. My name is Lauren. I'm a neonatologist and Associate Point of Care Ultrasound Director and Neonatal Hemodynamics Director at Orlando Health Winnie Palmer Hospital for Women and Babies. By the end of this talk, you're going to know common terminology for lung ultrasound, be able to identify normal versus abnormal findings, know the various applications of lung ultrasound, and highlight recent studies utilizing lung ultrasound in the NICU, basically arming everyone here with the ability and the knowledge to go back and use this modality in their own unit. So what are the benefits of neonatal lung ultrasound? It's portable. You can bring the machine to the baby rather than having to bring the critically ill, unstable baby to the machine. It's readily available in the unit. It's non-invasive. It doesn't hurt the baby. There's no radiation. And it has functional as well as descriptive applications. You can use it to make various diagnoses as well as to guide during different procedures and recruitment methods, such as that with trying to find optimal PEEP. But like with any good tool, there are limitations. It's operator dependent, for one, and it's really limited at evaluating deep pathology. So if you want to find out if a baby has pneumonia, if that pneumonia isn't close to the surface or the periphery of the lung, you may miss it. Also, the skill is not routinely taught enough in neonatology training, and so it's hard to distribute the skill around the country in various units. You also need access to an ultrasound machine and some sort of quality assurance when you're doing this as a program. In order to talk about lung ultrasound, we should first go through the different probes that are used in neonatal point of care ultrasound. This is not a full list of the probes that are used, but rather a small list that highlights the ones that I use most commonly in my practice. The probe we're going to focus on today is the linear probe. The linear probe is great for lung, vascular access, and lumbar puncture, whereas the phased array probe is really good for cardiac and cranial. And the curvilinear probe is used most commonly in the abdomen. Now, you can use these probes interchangeably if you only have access to one. However, it's good to know if you have all three, what is the best probe for what you're trying to look at. So why is the linear probe the best probe for lung ultrasound? It's got a very, very high frequency, which means it has a really high resolution at a peripheral depth. But once you start going more deeper, it really loses its resolution. So it's great for looking at artifacts around the pleural line at the periphery of the lung. It's really important to look at artifacts around the periphery of the lung, the pleural line, because that's really the hallmark of lung ultrasound. In lung ultrasound, you're not trying to see the actual architecture of the organ like you are looking at in CAT scans or abdominal ultrasound. In lung ultrasound, you are looking at interpretation of normal and abnormal artifacts. So let's go through these artifacts now. What you see here are two 2D pictures that I have taken in my unit. On the left is a picture of a baby with a normal lung ultrasound. On the right is a picture of a baby with an abnormal lung ultrasound. First, to highlight, the top is the subcutaneous tissue. Right under the top, you see the ribs. These ribs have an anechoic look to them or a hyperechoic look to them, depending on the angle of your lung ultrasound. Underneath the rims are these black shadowing. So this is acoustic shadow or acoustic rib shadowing. What this means is that the ultrasound beam is hitting the ribs, the bone. It can't penetrate through it. And so it sends a message back to the machine that, hey, there's nothing else behind there. And the machine says, great, and then puts black behind the ribs. The pleural line is one of the most important findings in lung ultrasound. As you can see in the baby on the left, there's a really thin or smooth pleural line in comparison to the baby on the right with an abnormal lung that has a very dense or jagged pleural line. The pleural line represents the visceral and the parietal pleura together. The visceral and the parietal pleura are a highly reflective surface and therefore shine bright or hyperechoic on the lung ultrasound picture. A lines are a normal finding in lung ultrasound and represent the reverberation artifact from the highly reflective surface, the pleural line. Whereas B lines are an abnormal finding in lung ultrasound, in which represent edema or intralobar atelectasis or fibrosis on a lung ultrasound. These B lines can actually be normal in neonates, especially neonates that were just born. And neonates that were just born, as we all know, they have fluid-filled lungs, and through various respiratory mechanisms, open up their lungs and move that fluid. However, when you do a lung ultrasound in those babies, you're still likely gonna see some fluid or some edema, and it'll be represented as some B lines, but certainly not coalesced B lines like we see in the picture to the right. Again, to highlight, on the left, you have your normal lung ultrasound, and on the right, you have your abnormal lung ultrasound. In the abnormal lung ultrasound square, if you see to the left, you've got these hyperechoic, very jagged, thick pleural line, and then these B lines coming from the pleural line. And then in the picture that is moving, this is a video of a baby with a very abnormal lung ultrasound. This baby has a large pleural effusion with complete collapse or atelectasis of the lung. And what you see is that hyperechoic lung floating within the fluid. It's important to highlight that in contrary to a chest x-ray where fluid is white, on lung ultrasound, the fluid is black. Now on to a different topic called about lung sliding. Lung sliding is a normal finding. This is where the visceral and the parietal pleura move against one another with respiration. You can see lung sliding in neonates even if they have no abnormal lung architecture. Meaning, in this baby with the video here, all the way to the right, you can see has abnormal lung markings with diffused B lines coming down vertically from the pleural line and almost moving back and forth in a fanning position. And you can see these little white dots where the pleural line is moving back and forth. That's called ants marching or normal lung sliding, as you see with respiration. I do want to highlight the baby to the left. In the left, you can see the baby has normal lung ultrasound findings with ribs, acoustic rib shadowing, A lines, pleural line. The baby in the B on B has a very abnormal lung finding, thickened pleural line, coalesced B lines. And then when you do M mode in that baby, even though they have an abnormal lung, you see this finding where you have the static area at the top of the lung ultrasound pictured, representing the subcutaneous tissue, and then the bright white line representing the pleural line. And then below that, you have this movement down the line of interrogation in M mode that represents the lung sliding. In a neonate with a pneumothorax, however, you aren't going to see lung sliding. This is where the visceral and the parietal pleura separate, making a barcode or absent lung sliding picture in M mode. You can see absent lung sliding in 2D, where you no longer have that movement back and forth of the pleural line or the B lines in that fanning-like area, or the lack of the ants marching of the pleural line. What I like to do actually when I'm trying to see if there's absent lung sliding is do M mode and see if I can find the barcode. So here in M mode, you have this arrow that shows the difference between the points of where the pneumothorax actually occurs, where you can actually see that separation between the visceral and parietal pleura. Where there is no pneumothorax or no separation between the visceral and parietal pleura, that's the seashore sign. Where there is the separation between the visceral and parietal pleura, that's the barcode sign. Where you see almost like a static area going all the way down. This happens because when there's air between the visceral and parietal pleura, the ultrasound beams cannot get through the air. And so what you see below is just a bunch of reverberation artifacts because the ultrasound machine cannot see that movement of the lung with respiration. Using ultrasound to guide a thoracentesis. So there is dynamic and static. Static is where you use the ultrasound to find the location of the largest amount of fluid, whereas dynamic is where you use the lung ultrasound in real time to guide your needle. When I'm putting a chest tube in, either for a pneumothorax or for a pleural effusion, I typically use the static mode rather than the dynamic, but it is completely up to you and your comfort level at using ultrasound at the same time as you do the procedure. This is a baby where my team was called because they had seen a large effusion on X-ray and they placed a chest tube and they were able to get fluid out. However, when they got an X-ray, they still saw a large effusion. When they called my team, we came to the bedside, and what we found was yes, there was still a large effusion. You can see the small area of subcutaneous tissue, that large black area representing the fluid. Then you have that poor little collapsed lung just flapping within the fluid, that little wiggling of the apex of the lung, that's called a squid sign. But I do want to direct your attention to the right of the screen where you see this hyperechoic line going up. This actually represents some septations that we were able to find in the effusion. What happened in this baby is the team had placed a chest tube in the usual fashion, but unfortunately, because of those septations, they didn't actually put the chest tube in the largest pocket. And we were able to guide them of where they should put the tube. Some other examples of using ultrasound in real time. This is an X-ray of a baby with a pacification of the left chest. This baby was admitted, intubated, had lines placed, had severe HIE, and no prenatal care. The same team that had had the experience of placing the chest tube a little bit too high and missing the large effusion for septations had this baby and said, can you guys come and take a look and tell us where we should put our chest tube? However, in this child, when we put the lung ultrasound probe on, we didn't see a large effusion. What we saw was actually the spleen and the lung moving back and forth and complete collapse of the lung, pushing the lung all the way to the right. So you can see there is a little bit of separation between the visceral and parietal line because you've got this black, tiny rim of fluid, and then the lung flapping around collapsed in that area. But obviously you would not want to put a chest tube into that area. When we looked further in that baby, what we found was the heart was everywhere that we looked. And this baby actually ended up having an undiagnosed Epstein's anomaly and was PGE dependent, some of which would have not been known or would have had a delay in diagnosis, or at worst, had a chest tube put into the heart had they placed a chest tube based on that X-ray. This is another example of a baby where use of ultrasound at the bedside changed clinical management. This infant is a left-sided congenital diaphragmatic hernia on ECMO. You can see the air on the left side of the chest, which was thought to be ex-vacuole, which we see very commonly with repair of the CDH. However, this baby was 2 weeks into the run and just really wasn't getting better. There was lots of conversations. Should we put in a chest tube on the right side to evacuate that effusion on the right side? And lots of concern with doing that because of being on ECMO. What we did, however, was do ultrasound to try to figure out how large is that effusion and is it a transudative or exudative effusion. However, when we did the ultrasound of the right lung, while we found a small effusion, we also found what looked like the lung kind of pushed over and pulsating. That's called a lung pulse. That is where you have collapse of the lung and it's pulsating with the beat of the heart. When we went up to the top of the chest, or zone 1, anteriorly on the right side, we actually saw the heart on the right side. And what we realized was this was not a large effusion that needed to be evacuated, but instead was a tension pneumothorax on the left side, so not ex-vacuole, and it had completely pushed over the heart and the lung to the right. When we saw this, obviously the surgeon said, I'm not putting a chest tube there. And we put the chest tube on the left to section, evacuated the tension pneumo, and by the end of the day, that right side had opened up. And by the next day, the baby was ready for clamp trials and getting ready to come off ECMO. My chief at the time said, hey, how did you get rid of all that fluid on the right side? And I got to say, funny thing, it wasn't actually fluid on the right side. It was the heart. And it was lung ultrasound at the bedside that helped guide our management. This is another demonstration of the baby that we spoke before, just highlighting that effusions look black on lung ultrasounds and look white on X-ray, but everything that's white on an X-ray is not actually an effusion. And prior to doing any instrumentation of a chest, I strongly recommend doing a lung ultrasound and making sure you know what you are actually going after and you don't incorrectly place a chest tube or a needle into a chest when there's not actually fluid, but instead the heart or collapsed lung. So now that I've showed you some interesting cases about how we can use lung ultrasound, what does the data actually show? Well, this was a pivotal paper published in 2020 that outlined guidelines and the clinical evidence for the use of various applications of point-of-care ultrasound. For lung ultrasound, it highlighted with pretty good evidence that we can distinguish RDS versus TTN, we can detect pneumothoraces and pleural effusions, and we can guide thoracentesis. We can also evaluate pulmonary edema. And then a little bit less quality of evidence is detecting anesthesia-induced atelectasis and guiding optimal PEEP and recruitment methods. One of the ways that you can do these things, the more functional applications of lung ultrasound, is actually through the quantitative lung ultrasound score. There's a lot of different published data on how to quantify a lung ultrasound score, and a lot of people that use various different techniques. The technique that I use is from Danielle DeLuca's group in Europe, where you keep the baby in the supine position, so you don't have to move them to prone, and you look at 3 zones. Zone 1, Zone 2 being anterior, and Zone 3 being lateral. And then in each zone, you do a score. 0 meaning no B-lines, 1 meaning some B-lines, 2 meaning a lot of B-lines, so more than 3 to 5 within the space, and then 3 having very large subpleural consolidations. And when you put those scores together, that's when you can actually differentiate some of these pathologies. With the quantitative lung ultrasound score, we can differentiate RDS and TTN. We can predict the development of bronchopulmonary dysplasia at 14 and 10 days of life. We can also evaluate endotracheal tube position. We can use that lung ultrasound score to assess readiness to wean off CPAP, to assess what readiness to extubate. The one that's so exciting to me is guiding diuretics and trying to find that optimal PEEP. So exciting because I love the chronic BPD babies. And we can also, not using lung ultrasound, but just a score, but using lung ultrasound itself, evaluate and intervene on pneumothoraces, pleural effusions, and large atelectasis. I wanted to end by showing you the AAP guideline table that was published in 2022. That is a call from the American Academy of Pediatrics to educate and operationalize the use of ultrasound in the NICU. This table separates if you're born, if it's right after birth or a little bit later after birth. So right after birth, if you do a lung ultrasound and you see B lines, then you look to see if there's more than 3 or less than 3. Again, remember that B lines can be normal in a neonate right after birth because you have pulmonary edema still. If you have more than 3 B lines, then you're looking at more of a pathologic lung. If they're coalesced B lines and it's homogeneous versus separated B lines or different lung points, that helps guide you into RDS versus TTN. If you don't see B lines, meaning that you only see A lines, remembering that can be normal. So then you look for lung sliding. If you have lung sliding present, it is not a pneumothorax. If you don't have lung sliding present, then you do M mode. If you see a stratosphere sign or that barcode, it is a pneumothorax, and a seashore sign is a normal lung. Later, after postnatal transition, if you see B lines right off the bat, you know it's a normal lung, meaning if you see only A lines, you should have a high index of suspicion that there could be a pneumothorax. If they're present and more than B lines, then you go down this pattern to see, is there a thickened pleura? Then you're looking more at chronic lung disease. If there's no thickened pleura and there's no spared areas of B lines, then you're looking at more a homogeneous lung disease like you would see in heart failure. If you see B lines that are homogeneous with or without air bronchograms, then you're starting to look and trying to distinguish between atelectasis and consolidation. I would highlight that while it is reported in the literature, especially in the adult literature, that you can see looking at the dynamic for static air bronchograms to determine pneumonia versus atelectasis. It's actually very, very difficult to do in practice and should be used in conjunction with your clinical experience and your clinical concern. So in conclusion, there are guidelines now that exist to use point-of-care ultrasound in neonates for lung. It's not just in Europe now. We have these guidelines with the American Academy of Pediatrics. Lung ultrasound isn't just descriptive, it's also functional. We can use it to guide for procedures. We can use it to predict morbidities. We can use it to predict morbidities and then hopefully down the road design different trials where we can actually put babies that are most likely to develop the negative outcomes, such as BPD, and then only expose those babies early on to different therapies. We can also use lung ultrasound to help us during resuscitations, to guide volume replacement therapy, to guide surfactant, and even ventilatory strategies. And despite the fact that there are so many different applications of lung ultrasound, it's actually one of the easiest things for us to teach, and one that after you do this course, my hope is that we'll have armed you with the knowledge and the skill to go back and do this in your unit. Thank you.